Welcome to the kitchen, where some polypets are trying to cook up a storm. After being forced out of their beautiful little garden homes after our last sketch, the polypet farm invasion, where we talked about how colon cancer develops, they found their way here to this lovely home. And here we have Papa Polypet. We remember him from our last sketch on colon polyps. However, things have changed for the worse for him. He started having a little bit of rectal bleeding when he wipes after having a bowel movement. Also, he notes he's lost some weight, 10 pounds, in the last few months. On further questioning, he reports he hasn't been doing anything special with his diet or changing his exercise pattern. He just feels his clothes are looser than usual. He's been a little tired as well lately. And on labs, sure enough, he's got iron deficiency anemia noted. Well, anoscopy revealed hemorrhoids, so there's the explanation for the bleeding, right? Does that mean we're done? No, of course not. There is no secret here that, being the third sketch in a chapter on colon cancer, that what Papa probably has is, in fact, colon cancer. But let's keep going to learn more about his symptoms. Both the screening guidelines for colon cancer and the process of carcinogenesis of colorectal cancer are covered in their very own sketches. So check those out for all the details. Here we're going to discuss the presentation and management of cancer. We'll start with some of the more common signs and symptoms of colorectal cancer. Symptoms of colon cancer are pretty dependent on where in the colon the cancer is. While it's important to remember that all of these symptoms overlap and could technically be seen with cancer pretty much anywhere in the colon, they can broadly be divided into left and right symptoms. We chose to split the fridge into the right and left sides based on how you would look at a patient or any imaging of a patient. So the left side of the fridge is to our right, just like the left colon of a patient laying on the operating room table is towards our right. Because the left colon is more narrow than the right colon, left sided lesions more commonly cause the so called changes in bowel habits, the most common of which is constipation. Constipation is also more common with tumors that encircle the bowel, narrowing the lumen. A commonly tested but not so commonly seen finding is the apple core lesion seen on barium contrast enema caused by narrowing of the bowel lumen. The barium in the region of the tumor creates the appearance of an apple core because the tumor occupying the bowel lumen prevents contrast from filling the whole lumen. The narrow lumen also compresses the stool passing through into a pancake or rope like shape, like toothpaste out of the toothpaste tube, but nastier. Imagine this stem is like the stool coming out of the top of the apple, and you should be able to see the picture. You may get it so well that you might not be able to unsee the picture. Anyways, in severe cases, tumors may cause acute large bowel obstruction, though it's much less common. Just like these ants are being obstructed in their pathway by the apple core, the tumor obstructs the passage of stool and sometimes even gas, and everything backs up, causing some serious problems. Typically, patients who get this have been ignoring other classic symptoms before the obstruction happens. Bleeding from the rectum, called hematochezia, is another finding extremely common to both left and right colon cancers. Bleeding can occur with tumors anywhere in the bowel, but it's much more likely with tumors of the rectosigmoid, where over 80% of them bleed. While bleeding may be occult or overt, left sided tumors are much more likely to cause hematochezia than right sided tumors due to their proximity to the anal verge. If this has been going on for a while, labs may demonstrate iron deficiency anemia. Due to the anatomy of the right colon, right sided tumors present a bit differently. Right sided colorectal cancers tend to present with occult or hidden bleeding, identified by iron deficiency anemia. Bleeding from the right side of the colon may also be seen as melena. Since the right colon is further from the anal verge, bleeding is often occult, meaning it isn't seen. No blood in the stool, no blood in the bowl. Patients will not suspect they're bleeding. Occult blood loss is typically detected on stool screening tests, like fecal occult blood test, or on routine lab testing, like a CBC. A commonly seen and definitely tested finding is unexplained iron deficiency anemia in an older patient, as in our clinical case from the beginning. In these cases, you must assume that the iron deficiency anemia is due to colorectal cancer until it can be proven that the patient does not have cancer. you have to assume that there's a tumor hiding somewhere, like this little polypet hiding back here. The reason is that colon cancer is so very treatable if caught early. So, if your first presenting symptom might be colon cancer, you better rule it out rather than let your patient walk around with unknown and untreated cancer. In addition to occult blood loss, right sided tumors may cause melena, which is black or maroon stools, often very sticky or tarry in consistency. This is less common. The difference between hematochezia and melena is the distance traveled and the type of stool the blood interacts with. In the right colon, blood from a tumor is exposed to fresh stool from the small bowel, meaning it's more acidic and may have digestive enzymes, and the distance it has to travel is fairly far to the anal verge, giving the acid and enzymes time to digest and alter the hemoglobin, turning it black. In the left colon, there's a much shorter distance, and the stool has had much of the enzymes and acid removed from it already. So the blood comes out red as expected. And finally, some symptoms are common to both left and right tumors, including abdominal pain, weight loss, and even hepatic involvement. Abdominal pain is a common symptom of colorectal cancer, which can be from partial obstruction, colon wall infiltration, or even peritoneal irritation. It's important to remember that abdominal pain can occur with lesions anywhere in the colon, but it may be one of the only presenting symptoms of right sided lesions. Abdominal pain has so many associated diagnoses that colon cancer may not be the first thing on your differential, but it should not be forgotten. In the same vein, weight loss may be seen with colon cancer in any location. While Papa Polypet might be pleased that he's lost some weight, let's clue in on the fact that he hasn't changed his diet or increased his exercise. We call this unexplained weight loss, and this is a worrisome symptom for cancer. If there's sizable metastatic disease in the liver, it can actually cause elevated alkaline phosphatase or even jaundice from biliary obstruction. Common? Not really. Which is why it's always tested on. The first step in any older patient with any of the aforementioned symptoms is colonoscopy, and for several reasons. First and foremost, it can look for a mass and, if present, biopsy it. So, our clinical case question for Papa Polypet is, with all these symptoms, what is the next best step in treatment? Well, it's simple. We just said it. He needs a colonoscopy. What about the hemorrhoids? You could band them, and in most cases, it'll probably be all that's needed. However, any older patient with any type of rectal bleeding, hematochezia, blood coating stool, blood with wiping, or even positive fecal occult blood, has to undergo colonoscopy. Non negotiable. It also helps to localize the tumor to a bowel segment and screen for any synchronous lesions. Finally, colonoscopy can also rule out other causes of bleeding, such as bleeding polyps or diverticulosis. So we've brought in our recurring colonoscopy flower symbol that you hopefully recognize. Oh, but we can't make it that easy on you guys. There's a whole lot more of the sketch to cover. Here's the second part of the question. Ha ha! We're talking colon cancer here, so here's a tumor shaped curveball. What is the most likely site of metastasis of colon cancer? Know the answer already? Well, let's keep going to see if you're right. With a tissue diagnosis of colorectal adenocarcinoma in hand, the next step in treatment is to figure out what you're up against, aka staging. Patients with colorectal cancer routinely undergo CT scanning of the chest, abdomen, and pelvis with IV contrast to look for both metastases and evaluate the extent of local disease. Baseline serum carcinoembryonic antigen, CEA, levels are generally obtained after the diagnosis of CRC as well. That's because CEA is a good tool for post treatment or post operative surveillance and prognosis, not for screening or diagnosing CRC. In fact, a CEA level that does not fall following surgical removal of the tumor is an indication to repeat imaging studies to look for metastases or retained tumor. After completion of a colonoscopy and imaging, it's possible to do a preliminary staging of the patient's cancer. The system for staging CRC is the TNM system, which doesn't stand for Teenage Mutant Ninja Turtles, like maybe I used to think, but rather stands for tumor node metastasis. The TNM stage system includes a standardized table for translating TNM scores into a cancer stage. The stages range from 1 to 4, with 4 being the worst. So, what actually determines each part of the TNM system? Well, strap in. This gets dicey. The T, or tumor category, is graded on the extent of local invasion by the primary tumor, not size. I'm going to say it again because it's just that important. In colon cancer, T, or tumor, is not based on the size of the tumor, but rather by the extent of invasion into the colon wall. We'll use this lovely lasagna to demonstrate the different layers of the colon wall, and the ants will act as our tumors. Thanks, ants. TIS, or carcinoma in situ, does not invade through the muscularis mucosa. Most of these tumors are removed by polypectomy, which is often treatment enough as long as the margins are adequate and the cancer isn't poorly differentiated. To review polyps and their removal, head over to our polypet mushroom harvest sketch. T1 lesions break through the muscularis mucosae and invade the submucosa, but do not reach the muscularis propria, i.e., external muscle layer. You can think of the propria as the proper muscle layer of the bowel wall, and the muscularis mucosae as simply a few muscle fibers just beneath the lamina propria, separating the lamina propria from the submucosa. Use the clues in the name to help you. Mucosae, submucosa, they must be close together. T2 lesions invade the muscularis propria, but do not break all the way through the bowel wall. Imagine this middle lasagna noodle as the muscularis propria. For the most part, T1 and T2 tumors are generally stage 1 and have over a 90% survival rate. T3 lesions invade to, but not through, the serosa. The serosa here is represented by the plate. Honestly, I remember this because we make a th sound when we say 3, and so I remember that it's to, but not through, the serosa. That may help you, may not. The serosa layer of the bowel wall is the same as the visceral peritoneum. Imagine the visceral peritoneum as a barrier to the rest of the peritoneal cavity. If the tumor gets through, all bets are off and it can spread quickly throughout the peritoneal cavity. So, not surprisingly, if the tumor gets through this layer, the seriousness goes up and so does the T stage. Finally, way over here we find the last ant. Boy, he made it a ways away. Just like the T4 lesions that invade through the serosa, or visceral peritoneum, and into the surrounding organs. Obviously, the higher the T stage, the higher the stage, and worse prognosis. Not surprisingly, the N, or nodal portion of the TNM staging system, is based on regional lymph node involvement. While there are a bunch of subcategories based on how many are involved, suffice it to say that if any nodes are involved, the TNM stage is automatically a 3 or 4. You won't do yourself any favors by memorizing all the N categories. Just remember that having stage 3 cancer at diagnosis affects treatment and overall prognosis. Take a look at the bread in this sandwich. Doesn't it look suspiciously like the Roman numeral 3, as in stage 3? And while we're on the subject of hidden objects, check out these pipes. Kinda like they're forming the Roman numeral 4. This brings us to the M in TNM. M is for metastasis. The M score is binary, meaning there's M0 and M1, and any metastatic lesion earns the patient an M1, which also automatically makes them stage 4. Well, at least the M portion is simple enough. Something important to mention, though, is that the 5-year survival rate for stage 4 colorectal cancer is very low, less than 5%. Oh, we're getting close to the answer for the second part of our clinical question. I can feel it. Are you guys as excited as I am? And since we're on the subject of metastases, now's a good time to review the colorectal drainage system. Wait, huh? Drainage? What has that got to do with metastasis? Well, turns out a lot. We'll get there in a sec. We've brought in the suspiciously colon like colonic edge of the sink to remind us about anatomy. The ascending and proximal 2/3 of the transverse colon drain into the superior mesenteric vein and ultimately the portal vein. The distal 1/3 of the transverse colon through the upper 1/3 of the rectum drains into the inferior mesenteric vein and again into the portal vein. As we just stated, the upper 1/3 of the rectum drains via the superior rectal vein into the IMV and then into the portal circulation. The distal 2/3 of the rectum has a more complex venous drainage that's covered much more in the anal rectal cancers video. For now, just remember that the upper rectum drains into the portal vein via the superior rectal veins and inferior mesenteric vein. If you're keeping score at home, you've probably noticed that a vast majority of the large bowel drains into the portal vein and, subsequently, the liver. It should come as no surprise then that colorectal cancer most commonly metastasizes to the liver, with the next runner up being the lungs. All right. There's the answer to the second part of our clinical case question. Now all we need is to review how we can actually help Papa Polypet and similar patients. Even though metastatic disease is automatically stage 4, it's not necessarily the end of the world. If possible, surgical resection of liver or lung metastases is done in appropriate surgical candidates, as it has a dramatic impact on cure rates and 5-year survival. If metastatic lesions are not amenable to surgical resection, they may be treated with ablation, cryoablation, alcohol, or radiofrequency ablation, transcatheter arterial chemoembolization, TACE or TACE, or even radiation therapy. All right, now for the only curative treatment of colorectal cancer: surgery. Cancers of the colon and upper rectum can be resected with a right hemicolectomy, left hemicolectomy, or even sigmoidectomy. There are a few other options for rectal cancers, so check out the anal rectal cancer sketch for more. First, a few key principles. Colectomy for malignancy involves removing the tumor with at least 5 centimeter margins on both sides, proximal and distal. Along with the tumor, at least 12 lymph nodes should be included in the removed specimen to aid in accurate postoperative TNM staging. This is usually done by taking much of the mesentery of the colon, as this is where the lymph nodes sit, and which includes the blood supply. Which brings us to the next requirement of surgery. Along with the tumor and lymph nodes, the primary arterial supply vessel and its associated mesentery should be removed as well. For this reason, simple segmental resections don't work for cancer. If you remove a major artery, you devascularize a large section of bowel. If that bowel were left in, it would undergo necrosis and cause sepsis. Thus, the colonic resection surgeries are all based on the blood supply patterns. For example, during a right hemicolectomy, the ileocolic artery, right colic artery, and right branches of the middle colic artery are all removed. This ensures adequate blood supply for the remaining colon, in this case, the left colon. On the other hand, if you don't take the vascular pedicle, lymph nodes, and mesentery, you run the risk of leaving cancer behind, which is obviously bad news. That's why, in addition to having wide margins, colon resection for malignancy ends up being more extensive than just cutting the cancer out. For cancers in the ascending colon or proximal transverse colon, a right hemicolectomy can be performed. In addition to the ascending and proximal transverse colon, several centimeters of terminal ileum and the appendix are removed as well. The vascular pedicles of the ileocolic artery, right colic artery, and right branches of the middle colic artery are removed to their origin. If the tumor is in the hepatic flexure or proximal transverse colon, the middle colic artery is ligated and a larger section of colon is resected, aka extended right hemicolectomy. For cancers in the distal transverse, descending, or sigmoid colon, a left hemicolectomy can be performed. For a left hemicolectomy, the colon, lymph nodes, and inferior mesenteric artery are all removed. If the lesion is isolated to the sigmoid colon, a sigmoidectomy may be performed. This time, the inferior mesenteric artery is taken, but the more proximal left colon is still perfused by branches of the middle colic artery. With the advances in technique and technology, there's now no difference in mortality between resections performed open or laparoscopically, depending on surgeon experience, of course. No matter which procedure is performed, primary anastomosis is usually possible. If not, a colostomy can be made either temporarily or permanently. Illustrated here are some of the more common complications of surgery on the large bowel. This includes injury to the ureters, like the spaghetti noodle getting cut, anastomotic leak, like the pasta sauce dripping out of the manicotti, or anastomotic stricture, like this guy stepping on the open noodle. In some cases, anastomotic leak can also lead to development of intra-abdominal abscesses. Whoa, what are these doing in someone's fridge? These toxic test tubes represent chemotherapy, which, while it does not cure colon cancer as well as surgery does, still has an important role. In patients found to have lymph node disease after resection, stage 3, adjuvant chemotherapy is used to reduce the risk of micrometastases. For colon cancer, neoadjuvant chemotherapy is not first line treatment. Here's where an important distinction between colon and rectal cancer exists. For rectal cancer, neoadjuvant plays an important role in the treatment algorithm, but for colon cancer, it does not. For more details on this, head over to our anal rectal cancer sketch. Following surgery, CEA levels are obtained around every 3 to 6 months to help detect recurrence. Immediately after surgery, there should be a fall from preoperative levels. If there isn't, there's a good chance that tumor was left behind or the patient has a synchronous lesion. Any sudden elevation in postoperative CEA should prompt reevaluation for recurrence, which can occur in up to 40% of patients following curative resection. Colonoscopy is recommended at 6 and 12 months post op to look for recurrence or new lesions. After the first year, patients should still have colonoscopy every 3 to 5 years. All right, well, let's sum all these colons up. Colon cancer symptoms often depend on the location that the tumor is sitting. On the left colon side, symptoms more often present with change in bowel habits. This includes constipation, an apple core lesion on barium enema x ray, changes in the stool caliber, large bowel obstruction or hematochezia, as well as iron deficiency anemia. On the right side of the colon, symptoms are less obvious. Patients may still present with iron deficiency anemia, but the bleeding is usually occult. With the cold bleeding, unexplained iron deficiency anemia should be assumed to be from colon cancer until proven otherwise. Melena may also be present if there's more than just a little bleeding. Melena is black or maroon tarry stool, which represents partially digested hemoglobin. Finally, some symptoms are nonspecific for right or left colon symptoms. Abdominal pain may also be present, though it's a very nonspecific symptom and can be due to many conditions throughout the abdomen. Weight loss is also common if the cancer has been present for a long time. If the cancer is obstructing the biliary system, it causes elevated bilirubin and alkaline phosphatase. This is relatively rare clinically, but often tested. Colonoscopy should be performed for any symptoms concerning for colon cancer, and biopsy if any suspicious lesions are found. Once cancer has been detected with tissue diagnosis, CT-CAP should be performed for evaluation of the local disease extent, as well as evaluate for any metastatic disease. CEA is a serum tumor marker useful for surveillance of the disease through treatment and to monitor for recurrence. It's a poor screening test due to high false negative rates. It's initially taken after the diagnosis of cancer and is expected to fall after surgical treatment. The TNM staging system is used for classifying the stage of disease. T stage depends on the local invasion of the tumor, not the size of the tumor. TIS stands for carcinoma in situ, which means it hasn't gotten through the muscularis mucosae, meaning the tumor is contained to the mucosa only. Once the tumor breaks through the muscularis mucosae, it has reached the submucosa and is now a T1 stage. T1 does not invade the muscularis propria. Once a tumor invades into the muscularis propria, or the muscle layer of the colon wall, it's now a stage T2. T3 stage tumors invade all the way to the serosa, but not through the serosa. Once a tumor breaks through the serosa, it's now considered a T4 stage tumor, and will often invade into adjacent organs or even to the abdominal wall. The N part of the staging system has to do with lymph nodes, or nodal disease. As soon as any lymph nodes are involved, the cancer is either stage 3 or 4. Nodal disease is often diagnosed after surgery, after enough nodes have been collected. And finally, the M part of the staging system is for metastasis, meaning colon cancer found anywhere outside of the colon, which, if present, makes the stage automatically stage 4. Reviewing the venous drainage is important for colon cancer. The right side of the colon, meaning the ascending and proximal 2/3 of the transverse colon, all drain via the superior mesenteric vein and then into the portal vein. The left colon, meaning the distal transverse colon, left colon, and sigmoid colon, all drain via the inferior mesenteric vein, which also drains into the portal vein. Finally, the upper 1/3 of the rectum drains into the superior rectal vein, and this drains into the IMV and then the portal vein. The distal rectum has a more complex drainage pattern. Given that the first organ the majority of the venous blood from the colon sees is the liver, it's no surprise that the liver is the most common site of metastatic disease and that the lungs are the second most common. These metastases may be amenable to surgical resection and, if so, dramatically increase cure and 5-year survival rates. Other methods of treatment of metastatic lesions are cryoablation, ethanol ablation, radiofrequency ablation, and transcatheter arterial chemoembolization, or TACE. The only curative treatment for colon cancer is surgery. Typically, colon cancer is resected with either a right or left hemicolectomy or sigmoidectomy. Adequate resection is determined by pathological evaluation of the surgical specimen after surgery and requires minimum of 5 centimeter distal and proximal margins and at least 12 lymph nodes for accurate staging. Maintaining adequate arterial supply to the colon is critical during surgery. This requires that the resection be performed based on the arterial blood supply and not just a simple segmental resection around the cancer. Typically, then, a right colectomy removes the ileocolic artery, the right colic artery, and the right sided branches of the middle colic artery. For tumors in the hepatic flexure or transverse colon, an extended right hemicolectomy can be performed, which ends up removing a majority of the transverse colon and is defined by the whole middle colic artery. For tumors in the left colon, a left hemicolectomy is performed and includes distal transverse colon, descending and sigmoid colon, with ligation of the inferior mesenteric artery and the left sided branches of the middle colic artery. For tumors in the distal sigmoid, only the left sigmoid colon may be taken, which only requires ligation of the inferior mesenteric artery, sparing the splenic flexure. Complications of these surgeries include ureteral injury, anastomotic leak, intra-abdominal abscess, and obstruction from anastomotic stricture. For patients with stage 3 disease after surgery, i.e., they have disease present in the nodes, then they're typically given adjuvant chemotherapy. For colon cancer, neoadjuvant chemotherapy does not play a role. For rectal cancer, neoadjuvant chemotherapy is important. For more information, check out our anal rectal cancer sketch. And finally, post treatment, patients require surveillance with CEA labs every 3 months